A warm welcome to the Munich International Symposium on Health Promotion, Mind-Body Medicine and Yoga. I also welcome you in the name of my colleague Dr. Sanjay Phadke. First of all, a warm welcome to Professor Sartorius, our chief guest. A warm welcome also to our Indian guests from the Indian National Psychiatric Association and from the task force of body-mind medicine of this association. A warm welcome also to our Skype speakers. First of all, Professor Gangadhar from the Indian National Institute for Psychiatry and Neuroscience, and to Professor Leena Phadke from SKN Medical College in India. A warm welcome also to the speaker and the chief guest of the Bavarian Health and Safety Authority, Professor Wildner and Dr. Spegel. A warm welcome to everybody in the hall and to everybody who will see this video afterwards and will participate in this way. Professor Wildner and Professor Sartorius, so that we can meet later. The idea of this symposium came from Dr. Phadke after the Indian Psychiatric Society made him chair of the task force of mind-body medicine. So we asked Professor Sartorius whether he will be ready to come as a chairperson to the symposiums, and we are very happy he agreed. Professor Sartorius is the former director of the World Health Organization Department of Mental Health, and he is a person who influenced the health promotion worldwide the last more than 30 years most. So we are very happy to have him here, and he will talk on global perspectives on health promotion, opportunities and challenges. Please, Professor Sartorius.
I will speak about the global perspective of health promotion. The word promotion of health can really have three very different senses. It can be that you say we want to promote health in Bavaria, so you say we will promote it by reducing the number of people who are sick. Fewer people who are not well means the health has been promoted. In other words, if I remove much of the disease, I have promoted health. That's one way of interpreting the word promotion. The other one is that promotion is not to do with disease. It is to do with enhancing and making people more healthy than they are, strong, able, intelligent, resistant to disease, fantastically developed. That's another one. You're promoting the health. In other words, you are making it higher and more important. And the third word is the neither of the two, but the third word is the promotion is in fact nothing more than heightening the position which health has on the scale of values which people have. Every one of us has a scale of values, and we say patriotism is more than red lips. Or it's the other way around, people buy lipstick. If they believe in patriotism, they buy books. But every one of us has specific scale of values on which we are putting. We put our family on this scale of values, our society, our government, what we are doing, our profession, our patients. So at present, mental health worldwide is very low on the scale of values. It's at the bottom almost. That's why governments don't give money for it. That's why society as a whole doesn't promote it sufficiently, because they don't think it's very important. And in a way, we could promote health by putting it higher on the scale of values. If health was as important as beauty, for example, it would be much easier to do things for the health care. But since it's not as important, it's more important to be beautiful than to be healthy. So if you are very beautiful and you are not healthy, that doesn't matter so much. But the other way around, it would matter. So these are the three ways of thinking about the promotion of health. And each of them has an advantage and a disadvantage. So if we were to say that the health is, in fact, promotion is to reduce the number of diseases. We do not want to have diseases. In other words, we want to cure those who are not well, and we want to prevent the occurrence of new diseases. That is the first sense. In that case, you will have these kind of people who will be mainly concerned. Psychiatrists will be treating people for mental illness. General practitioners will treat them for physical illness. Other practitioners, but basically all of these people are somebody who is trying to reduce the disease in the person. Also, it will be necessary for the government authorities. They will have to provide special laws. For example, the government will create a law that bicycle riders must wear helmets, because if they don't, people fall from the bicycle and kill themselves, or which is worse, they remain alive, and then once they are alive, they are invalids for a long time. That's very expensive. They cannot do it. So the government also participates in a whole series of rules which make it possible to prevent illness, and that is the second one of them. Then there is the third group as well. For example, in the area of mental health in particular, we are unfortunately almost completely neglecting the enormous possibilities for prevention, for primary prevention of mental disorders. You know the difference between the primary, secondary, and tertiary prevention. Primary prevention is do something so that the disease never appears. Secondary prevention is when the disease has appeared, let's do something, it doesn't leave trace. It doesn't result in invalidity. And tertiary prevention is that you have a person who has been ill, but now you want to reduce the number of impairments, the disability which remains after illness. But primary prevention in mental health is enormously possible, but unfortunately completely neglected. Take, for example, the provision of iodine to women who are in a fertile age. At present, every year in the world, there are about 12 million people who are born cretins because their mothers did not get in time iodine, which they could have gotten either through salt or through an injection or through other ways. So we could prevent completely 12 million people born as cretins every year if we did something about getting iodine to women. Of course, psychiatrists cannot do this. They have to speak to the government, and they have to convince the government that iodine in the salt is important. But psychiatrists don't know how to speak. Nobody understands them, and they never go to the government. They never go to say, please, you must do this. They stay and look after patients. So they are not interested as much in prevention as they should be. There is a variety of other diseases and conditions which could be reached by primary prevention, but are not because nobody does it. Still, there is a variety of this. Then there is also another group that would be concerned with if we think that the promotion of health is reducing disease, that would be various civic organizations, patient organizations, family organizations, other people, what has now become very popular, peer organizations in which a person takes another one who is not well and looks after him, etc. So there's a whole range of other organizations which will be involved. And of course there are the family members and the carers of other descriptions. All of these people are working on the promotion of health as being related to disease. They don't care about what the person is, they care that the disease disappears. Now that is very nice, but people say, wait a minute, we should in fact do something to enhance the health as such. But there are advantages to this first definition. First, it is very possible to clearly define what you want to achieve. You can say, I want to reduce the rate of suicide in my community. It's very clear what you're saying. That's an advantage. Because for various kinds of health promotion, very often it's difficult to say what will promote health. People will be a little more frequently smiling. That's not a very powerful indicator. You want indicators that are strong, and suicide reduction, for example, would be a strong indicator. The second great advantage of this one is also that you have a very solid scientific body of knowledge that you can use in order to treat mentally ill people or prevent mental illness. So there's a lot of knowledge that we have, and science keeps producing new knowledge about that. Then there is also an advantage that you can also see how much you have done over a certain period of years. It's not only the absolute gain, but also the gain specifically related to a particular disease. And then, of course, the population, people, are very much happy with that. If you can say we are removing disease, they applaud. This is very good. Everybody understands this. My father has cancer, now he doesn't have cancer. I'm happy. So the notion of reducing disease is something that everybody understands. And therefore, so much of the promotion of health has been exclusively related to the removal of disease, through prevention or through treatment. Now, if you say that we are going to do something else, the promotion of health is making people better, stronger, more empathic, more understanding, in better harmony with nature, all of these things, it's difficult to measure that. People will say, firstly, you could of course say that if you have an increased capacity, they will be better able to deal, if disease comes, to overcome disease. But that's a difficult argument to have. Still, it is an argument. You could also say that humans, if they have an increased capacity, will create an environment that will be wonderful. Intelligent, pleasant, hard-working, everything you want. Of course, they will create an ideal world. You could say that. And many of the people who are thinking about promotion as being an increase of the normal capacity to a higher level, almost one would say supernormal, are in fact arguing that very strong. And they also said that they would create a better society. There's no proof that that will ever happen. In fact, there are proofs that trying to create people of extraordinary capacities has been worse for society in the course of time. So one has to keep that in mind. Nevertheless, there is something to that. One could say with a limited and reasonable amount of health promotion, you could create people who are better people. But one has to be known what it is. Of course, the disadvantage of thinking about health in this way is that there are very, very few people who are good teachers. Because to create these people of extraordinary capacities, you would have to have extraordinary teachers, but there are none. There are very few of such people who are wonderful teachers of how to make a better human. So miserable people teach you, and therefore you don't get very far. And I think that's what really is the result. Now the third of these advantages, the third one would be to say, no, we don't care whether the disease goes up or down. That's not what we are doing. We are not caring how much people are better today than they were 2 centuries ago. We are going to say that all we want to do is lift health on the scale of values. We shall put health higher than beauty, or higher than patriotism, or higher than everything. Health will be our chief value. If we manage to achieve this, of course, then the Minister of Health will be higher than the Prime Minister, because he is dealing with this. This is not always possible. So I think, but once you even lift it a little bit up, you suddenly find that money becomes available, that people are concerned, that people come along, etc. So there's a whole range of consequences which are positive if you lift the value of it. When do you have to start? Well, you have to start thinking about the value system approximately end of the first year of life. Because it's at the first year of life that the child starts understanding what goes on around him. Does he greet the mother first? When somebody comes through the door, is the woman greeted first or the man? That is an observation at the first year of life. And as life goes on, we are gradually in our surroundings building people, building their value system. So by the time that they get to school, they already have prejudice of all sorts. And as they go up, this becomes more and more. And at the age of 6, there is a strong prejudice against mentally ill people already. and all sorts of other things are already formed. Still, at the early days in school, you can influence if we were not so stupid as to teach people about kings instead of teaching people how to live with other people. We should learn how to live with people. Who is this person next to me? What do I do to live in the same society with him? No, I can list for you all the kings in my country. There are many of them. They all have the same name, so it's easy. But I mean, there are two dangers if we put health very high on the value. Two dangers. The first one is that those who are not of that kind of high health value will be considered miserable and will be thrown out. If you have everybody who is an athlete, one who cannot run is being rejected. So one has to lift the health while at the same time trying to lift also the tolerance and the sense of inclusion, the sense that we are a society. That has to go hand in hand. Otherwise, lifting the health on the scale of values is dangerous. And of course, you must realize that as soon as you put health higher, something else goes lower. And the question is, what can we allow to go lower on the scale of values without losing what we have? Today in the car, we were talking about something, and that is that there is a significant change in societies, particularly in Europe. And the change that happens in societies in Europe these days is that the middle class is diminishing. The number of people who are in the middle class is smaller. My grandfather, who happened for a while, he was a professor, he was a director of a small factory in Lübeck. So happened because at that time this was the Austro-Hungarian monarchy and they moved the engineers left and right. He was there, he had a wife, he had 4 children. He had an aunt which belonged to nobody, so he had looked after her. He had a mother of his wife and then her brother. All of these people lived from his salary, and he was only middle class. And if you look at the development, now you find that many families have to employ both men and women, if they are a couple, in order to live a normal life to which they are used. And the total, what the Americans have a wonderful book about this, which is a play on words. And those of you, the play on words is, the book is called Screwed. Now, screwed means either if you do this, but also has a meaning that in front of these ladies I cannot pronounce because it's so bad. But it is in fact that the middle class, under heightened taxes and at the same time considerable loss of what they normally had before, is diminishing. With the diminution of the middle class, the morale of the society has no protectors, because it's the middle class which protects the morale of society. If the middle class gets small, there's no morale. The poor never had much moral rules, nor the rich. It's the middle class which carries society around. And as the middle class diminishes, we get all these phenomena that we see today in societies of a significant decrease of observance of rules such as empathy, charity, friendship, interdependence, all of these things that are important for a good society. We can come back to that in the discussion if you wish. So, what is the reasonable choice between those 3 types of promotion? Diminution of disease, making people fantastic, or increasing the value of health on the scale of values? Well, the best is to do all 3, of course. That's not always easy. I think that if we could do it, if we could put health a little bit higher, and if we could create people, it would be so much better. And therefore, probably, I would say, going from the beginning, I would argue for an increase of the value of health on the scale of values, because it will increase the possibilities of doing other things. It will make people more able to do things. Now, the easiest thing to do, as I told you earlier, is prevention. So we don't want to even talk about it, but psychiatrists would have to go to the ministers to speak to them and to make them sure that they do it. So I think that the 3 types of promotion are 3 facets of the same phenomenon. That you have to lift the value in order to get the money to create prevention, and to create teachers which will change people in their ways. And if you manage to do all three at the same time, it'll be possible. At present, for most countries in the world, the budgets are still very low, and lifting these budgets up will not be possible until we increase the value of health on the scale of values. Now, I think that I've listed here in red that these three different things that we should probably do it, and that we can probably do without difficulties. Now, what could different sectors do to promote that? I think that we could, for example, in the field of health sectors, and that is something important, we could start working against the fragmentation of medicine. Medicine is falling apart into 1,000 specialities, but nobody thinks about the human being as a whole. So now you have internists have now 11 specialities in Belgium, 44 specialities in Mexico. Different kinds of things. I recently was in an aeroplane, and as I was going in an aeroplane, next to me was a person. I said, what we are doing? He said he was a surgeon. I said, any speciality? He said, yes, it's the right thumb. I said, excuse me, I don't quite understand. No, he says, I'm a hand surgeon, but I have focused on the right thumb. That's what he does. He does a lot of money. He doesn't care who is hanging on the thumb. This is somebody else who does this. He is the thumb man. And there's other people who are some other type of organ. I don't want to mention all the organs which you can be. But I mean, the medicine as a whole has fallen apart. That you have now, and there are symptoms of that. In America, they have introduced a new category of health personnel, which are called case managers. Now, a case manager is a person who is employed because the patient cannot know anymore where he should go, whom he should ask, what is happening. He doesn't understand anything. So this person does nothing but follow the patient so that they find the right way. It is a terrible signal of a medicine that doesn't function. So that you would want to see somehow that a person who comes to the doctor can, in collaboration with that medical doctor, create all that is necessary to get well again. But that is not necessarily happening. So I think that is the first thing that we should do. And here is something that maybe for this group might be of particular interesting. We also see that while medicine is becoming fragmented into ever smaller disciplines, people are becoming more and more often struck by comorbid diseases. They are not long anymore sick with one disease, but with 2, 3, 4, and more. So that you have the population which grows older, and as the years go by, people are more likely to have more than one illness. A little bit of a heart problem, a little bit of a kidney, maybe a pain in the back, maybe also a little bit of depression here and there, and then maybe something else. So they have 5 or 6 diseases to be treated by 5 or 6, if not more, specialists. They can't do it. So that while humans are becoming more complicated in their illness, medicine is not capable of dealing with it. And I think that the comorbidity as such is becoming the rule of the day. We now see that the extension of life that everybody speaks about, we have an extension of maybe 20 years of life, no? If you compare 1950, 55 with 1980, 90, we are now having 20 extra years of life. Not 1 year free of disease. The total extension of life is an extension of sick life, of diseased life. We are treating these diseases and we are doing quite well. Diabetic people run about in circles to get enough exercise and get insulin and something else and other medications, etc. So do the cardiovascular. But all of these people are not without disease. We have not managed to create 20 healthy lives, where you would be without any disease for 20 years. No, that we have to achieve still. So you have comorbidity growing and medicine being fragmented. And that is something that is a terrible proposition. Now, the second thing which we should do after we have revised the strategies about improving health care in a significant manner, avoiding the case manager, avoiding the fantasy of community care Community care is something that everybody speaks about, particularly in psychiatry. But the problem is there are no communities anymore. Communities have vanished. In a country like Argentina, 95% of the population lives in towns. Those 95% have come into towns in the last 30 years. They know nobody. I'm living in a 7 stories house, 8 stories. And after 8-9 years of living in there, I know one person who is taking the dog out at the time when I go to work. So we say, hello, how's your dog today? Fine, thank you. And I cannot imagine that if I were sick tomorrow, that he would let his dog away and would look after me. No, he would continue taking his dog up and down. And I would not have a community to which I can fall. So that the notion of community care is also vanished. And I think that those two things, number one, the notion of revising health strategies to really start thinking about them differently is very important. But the second one, in order to carry this, we have to change the education of health workers. We have to think of, are our doctors capable of having all the knowledge that they need to approach in this way? Can a doctor today, who is a psychiatrist, understand and see a kidney disease? Or does he know how to advise a patient who has diabetes as well as a depression? Do the diabetologists know what to do about depression? Absolutely not. We've just completed a very large study in which we looked at 3,000 people in 12 different countries. And what we did, we took a sample of people who are treated for diabetes, and we looked at their record. They've all been treated for at least a year. And we've examined every one of them by a very well qualified person, and found that approximately 10% of them had depression. That is about twice as often as in the normal population. Normal population is 4 to 6%. Diabetic people, twice as frequently, about 1 in 10. How many of these have been recorded in the Department of Diabetics? 1%. 1%, 0%, 5%, nothing more than that. So that in fact they will be treating for diabetes at the same time having depression. And we know today that when diabetes is together with depression, the outcome of diabetes is worse. People have more complications, they have more problems. And equally so, if you don't treat depression, it gets worse. So instead of providing treatment to both diseases, they get treatment for one disease in this clinic, and maybe over there in another clinic, another treatment. So we should gradually change the education of health workers, because that will be enabling them to at least see and think. In England, they've resolved, they'll do it with money. They give you a little extra money if you, when the patient comes through the door, you give him a questionnaire. And the questionnaire tells you that he may be having a depression. So they get an extra penny, and they know, oh, you may have a depression, so they send him somewhere. But I mean, the normal education did not make them want to understand what is the totality of illness that is present in this person. What is it that I have to do to make that person better again? The third thing is that we should start thinking about how do we report the success of what we are doing. We have I think that we should not only look at whether there is a lesser number of people who die, but we should also look at other statistics. And many of the statistics have nowadays been reduced and have not done very well. Unfortunately, local communities stopped producing results which you compare. I do not know how it is in Germany, but in many other parts of the country do not report to one another any longer. They are not putting everything into the same. And when you get statistics, it's usually 5 years later they tell you how many. So it is, however, unfortunately, we should be very clear at the end of the year, and there are techniques which can allow you to continuously measure what results you are achieving by our various measures. That, unfortunately, is not going on anymore. The World Health Organization was previously having a regular annual report of diseases in the world. No more. The only disease statistics which WHO today produces is the weekly epidemiological report to measure whether cholera and 5 other diseases are appearing, but nothing else. How many people are there with diabetes? How many people are with some other disease? Mystery. And it's all now estimates. And very few countries have in fact a decent way of measuring. They have better mortality statistics. They know what people die from, but they don't know what they're sick from. And so that is something that one has to correct as well. And I think that we should also operate in the last line, which is to use the education much more differently. On one hand, to educate children differently, educate them from the beginning. But more importantly, perhaps, we should start educating parents. Because I've recently met a friend, unfortunately he and his wife cannot have children, so they decided that they would adopt a child. And a rule is that if they want to adopt a child, they must go through a course, 6 months, to learn what to do with a child. So why are these so stupid and the other ones who make their own children are not so stupid? I mean, these who make their children are not any wiser than these other people. So why are these people not getting 6 months training on what to do with a child once they have it? It's crazy. And sometimes you have to do strong measures. So I remember an incident in Mongolia. We were going to what is called an IMAC, which is a nowhere. And I was going there and I said, what do you, show me a little bit about your healthcare system. And here he was showing me what they were doing. The health worker is on a camel or on a horse. And he rides around, and there are many nomadic people there. And so he goes and looks who looks a little pregnant. And he finds this woman is a little bit pregnant. So he, about in the 8th month, he takes the woman and he brings her to a station, which is a health station, where she has a little room, a bed, etc. And she gets 1 month's training what to do with a child. And during that time, she also has not to be exposed to terrible, very unpleasant or dangerous work for her and her child. So that is so far understandable. And then after 3 or 4 weeks, she has a baby. Now comes the great thing which is not happening in our countries. The same health worker rides on a horse out, takes the husband and brings him to the clinic and makes him look after the child for a week so that they learn a little bit. It's a primitive, very simple training. But among other things which they do, I found them wonderful. The pictures which they had in Mongolia was Angela Davis, Marie Curie, women who have achieved great things. So when she's there for these 3 weeks, they say, you're not stupid and small, you're big and clever. Look, think about it a little bit. They lift the sense of value of these people to an extent, and they teach them how to do children. Now, I find that our societies here in Europe have unfortunately forgotten their duty to prepare parents for the child which will come. Some of people do it on their own strengths, but very much less than before. And in addition, since the families are smaller, the grandmother service and the aunt service and the friendship service is much lesser. So that many of the women who now come forward, they say, I got this child, I don't know what to do with it. How do you educate, how do you make them smile? What is it? I smile at me. Yes, everybody smiles at the child. No one makes funny figures. But what else do I do to make it a good human being? And then, not sooner than that, they also have to leave them in the hands of very often a less qualified person who will look after the child while they are going and getting some money for it. So I think that the education from the day one throughout is something that would be terribly important to create values in people which will allow you to move healthcare. Now, finally, the law should also be used. The law has to be, in a way, thinking about health promotion. Very often it is left in the hands of the health system. Health system by itself is not sufficient. It has to have the support of other sectors, and the other sectors have to be motivated by legal force. So these are the, I would say, the 5 things or 6 things that we should think about. To revise healthcare, to change the education of health workers, to think about presenting results in a manner that will allow us to change direction if necessary, to use education from day one of everybody. The wonderful results of the self-help kit that has been produced in Australia for dealing with mental illness in the community is a good example. And finally, they should also use laws to do something about it. So I think that we should think about introducing those three components of healthcare, because if we don't, we will see that the cost of care will go up. It continues to go up because we are doing things wrong. And it increases much faster than we ever thought. We should also, I think, finally understand that prevention is the main area in which we should work, not treatment, because prevention at present is so much more promising and so much cheaper, and we can touch so many more people with it. We will also, I think, if you don't do it, people will become less and less happy with their health care. They're already very unhappy. Money has been invested into health care. And what do you find? The only group of people who are getting more patients are traditional healers. Hand layers, magnetizers, all of these characters. There are now 85,000 of them in France, more than traditionally trained doctors. And everybody goes to them. Why? Do they know much? No, they know how to listen. It's a big skill. Nobody teaches you in whole of medicine how to listen. They teach you how to speak and how to give advice. But listening, no. That is natural, comes from God. It does not come from anybody. So I think that we could increase the satisfaction with healthcare if we did it differently. And then we could also maybe deal with this problem, which is now a huge problem in healthcare. And that is that the healthcare workers are having a very high rate of burnout. Burnout is a syndrome that is characterized by dissatisfaction and lack of will, and very often some other psychological symptoms, which comes from being thoroughly unhappy at your work for too long. And that creates the syndrome. It's very frequent. Now in young doctors, 50% of them in Europe have symptoms of burnout. 50%. Which means that they don't like what they're doing. And what they are given to do, they don't like either. And the general population also has a sense of malaise and ill feeling for reasons that are not there. So we could, in fact, prevent, if we did some of these things, also the burnout. So, ladies and gentlemen, I just wanted to throw these provocative thoughts out, and I'll be delighted to participate in a discussion with you. Thank you very much.
Now on Skype, we are happy to have Professor Gangadhar. Professor Gangadhar is head of the National Indian Institute for Neuroscience and Psychiatry. He is member of several Indian commissions for mental development, for doctor training, for yoga, etc. He is one of important yoga researcher. He researched on oxytocin, which is used with patients in schizophrenia. He will talk today on blueprint of transformation of medical education and health care in India. Please, Professor Gangadhar.
Good, Navin. Okay, in the coming 10 minutes, let me share what has been happening with respect to the impetus being given to integrative medicine in our country, and how we have experimented with using one component of yoga as an integration into mental health practice in our own institute. Quickly, let me give you various types of health disciplines in our country. I'm sure many of you would already know these things. We have Ayurveda, we have Siddha, the yoga. Each of them are a couple of thousands of years old, practiced from the Vedic times as much. And little more recently, we have introduced the Unani, and of course, homeopathy is something that you already know. It's from your own country. The Tibetan and the Buddhist style of medicine, Rigpa, has also become formal in our country. So these six conditions, these six health disciplines have been considered as traditional have been put to use in our country. And since the colonial era, we also had opportunity to use the allopathic systems, which have an history of about 150 to 200 years. And more specific medicines became available in the last 100 years. Each of these had a philosophy, had an explanation in their application. For example, Ayurveda used what we call as the 5 elements in the nature, which operate in a synergistic way, bring about changes in 3 levels of our body function, producing wellness or illness. Likewise, Siddha also believed in a similar theory, and the yoga, although did believe in that, had a little different style of approach to health, using 8 limbs of lifestyle practice. Yoga is largely spiritual in its approach, and by being spiritual, you could guard your health. And the Unani also had similar thoughts of 3 basic humors, which are made abnormal, causing illness. Homeopathy, of course, has a totally different approach altogether, which you know it best, although these have been put into use in our own country. The Rigpa had similar thoughts of Ayurvedic principles, and of course are largely used by Tibetan people. And of course, the modern medicine, allopathy, believed in what we now call as evidence-based reductionistic approach in our healthcare. All have been effective, although the last one has been introduced into mainstream. So much so, the other 6 systems had a slightly lower key operation in our own country. If you see the slide here, we have about 800,000 traditional system doctors in our country, as against about 1 million allopathic systems of doctors. In the traditional system, which we have been practicing, we have about half of them, or even more than half of them, practicing Ayurveda and a few others, different systems of medicine. The yoga, although is a part of wellness lifestyle, was not introduced as a treatment to illness, although more recently people have evolved into what we call as yoga therapists. But in its initial introduction, yoga was a treatment, was a practice for a spiritual transcendence, which of course guarded our health. These systems of traditional systems of medicine, vis-a-vis the allopathic treatment, had a difference, which is generally considered as these systems actually promote wellness, whereas the last one helps in getting the illness out. If you see the trends that have been happening in the last 5 years, the Government of India Health Department has placed emphasis on wellness more than illness. So the Government Health Department created or is going to be creating 150,000 wellness centers, which not only, of course, treats illnesses, but essentially promote wellness. And when you are talking about promoting wellness, these traditional systems of treatment become extremely important as compared to the allopathic system. The traditional systems of treatment had now become very formal. Earlier, it used to be considered as informal. All of these have councils of their own. Recognized degrees are being given. Postgraduate education is also being offered in some of the conditions. And the centers which use these approaches to treat patients have also been established in our country, all over the country. And more recently, these are co-located with the allopathic systems of treatment, trying to mainstream the Ayush, the Ayurveda, Yoga, Unani, Siddha, and homeopathy-based treatments are now being encouraged to be in the mainstream as much as possible. So this brings in the issue of integration. Have we really integrated the traditional systems of treatment with the mainstream treatment of allopathy or not is a question that is being asked today. In fact, integration is something that we have emphasized but not necessarily practiced as much as we would desire to happen. In fact, from the time of 1940s, integrative medicine has to come into place, is being discussed in various committees that were set up by the government. In fact, as recently as about 2 decades ago, the Indian Council of Medical Research in its national health policy emphasized the need for integrative medicine, integrating traditional systems with allopathic systems of treatment. Most recently, just about a couple of months ago, the national education policy, which also emphasized pluralistic medical education. Medical education should carry both some knowledge of traditional systems and knowledge about allopathic system that they are learning. And they have clearly said these groups remaining in silos and operating in that way has to be slowly discouraged, and people have to come out and use different systems of treatment as complementarily, as additively as possible, and all should know each of these as much as possible. So this concept has been slowly getting consolidated in the recent years. We have been using traditional systems of treatment before the allopathic systems came in the colonial era, late 1800s to be more specific. Earlier to that, the traditional systems generally considered as informal. The formal system was introduced as allopathy, and later on the allopathic systems realized that more inputs are required beyond a mere medicinal treatment that the allopathic doctors were doing. And so the traditional systems were being examined. There have been, in the last 3-4 decades, traditional systems have been examined in clinical trials, and people have examined their mechanisms of action, understanding their basic biology. And so the traditional systems, which have now become formal, are beginning to be accepted. The traditional systems have become popular. For example, the yoga, after the Honorable Prime Minister of our country announced it in the UN in his talk, became a formal practice. Yoga is now an international day of yoga is also observed. And many institutions have started using yoga as a form of treatment. I'll come to that a little later when I talk about how we introduce yoga for integration. And people are also slowly realizing that allopathic systems of treatment are more expensive, and a lot of people would have tried informally or even by choice formal Ayurvedic or traditional systems of treatment. So this is the background in which we have seen traditional systems replaced by the allopathic systems, and they enjoyed popularity because of their specificity in action, preventing some of the dreadful diseases by vaccinations, and also good nutritional supplements that were able to treat nutritional deficiency diseases. Many of these things, infectious diseases and some of the nutritional diseases, made a dramatic change in the health conditions during the previous century and the early 19th century as well. So they played an important role in getting themselves mainstream, but the emergence of the non-communicable diseases, including psychiatric disorders, where the treatment has now become multidimensional. In fact, their causes are also multifactorial, and so the doctors and the health department realized multiple inputs are required. So it looks like the wheel has made a full turn. For example, very recently, a JAMA article talked about how in mental health, for example, treating psychiatric disorders, from the time we were using multiple inputs, reached to one receptor, one neurotransmitter, one drug, and now we are moving into multiple causes for psychiatric disorders and intending to use multiple inputs again. The emphasis on multidisciplinary treatment approaches has come into place. So here we are talking of integration. Integration is not merely using one or other treatment, rather using both a traditional and the modern treatment complementarily in a judicious polytherapy combination. We've been recently talking about judicious or rational polypharmacy. We probably have to introduce rational polytherapy as well. So from informal applications of traditional systems which people chose on their own, can we make formal courses of lifestyle medicine which can come into modern medical practice as well, and the integration has to be made more formal. So the general consensus which is emerging is that instead of master of one, to become master of all if possible. If not master of all, you should be able to use judiciously several systems of treatment. And treating an illness, which is the focus of an allopathic approach, to treating a person with illness or making the person well, is the concept that people want it to emerge over the course of time. So in other words, we apply best of each profession as comprehensively as possible. So here we have in NIMHANS, we used yoga for introduction in the yoga center to begin with about 11, 12 years ago. We gave it as a service. It has been catching and getting attractive. As many as about 50 referrals happen every week, and each day about 60 to 70 patients get this treatment along with other modern medicines. If the patients are referred from psychiatrists, or if some patients choose only yoga, also it is possible for them to avail this treatment. Research by modern medical doctors, those who are pursuing psychiatry, neurology, or other PhD research, they're also using yoga for their research agenda. And more recently, we have also introduced Ayurveda along with yoga, plus or minus allopathic treatment as a comprehensive package in the department called as the Integrative Health Department. The process of functional integration in courses is going to happen very shortly. So to summarize as a future direction of where we are doing, how to take yoga, how to take integrative medicine forward, this is my approach. Yoga is something that should be integrated into all medical disciplines, whether it is Ayurveda, Siddha, homeopathy, Unani, or even allopathic medicine. In all these systems, there is a place for yoga as a wellness medicine subject. We should be able to introduce what we call as diploma in integrative medicine for primary care physicians, diploma in integrative medicine for different specialists with a focused approaches of using yoga plus other integrative approaches in these subjects, in these specialities. We also have to integrate all the existing traditional systems. As I have shown in the earlier slide, many traditional systems share some common beliefs, philosophies, and theories. Is it possible to bring all the traditional systems under one banner? We would probably be able to introduce an undergraduate course of integrative medicine, which will comprise of both traditional and the allopathic systems of theory and practice. And the Ayush practitioners, that the traditional systems of health practitioners today are not very familiar with the modern science. The modern science which drove the allopathic science, allopathic medicine into greater heights, be able to introduce the molecular basis or be able to get the best combination of drugs, etc., understand the genetics, genomics, and such modern health subjects. If the Ayush practitioners are able to put into use, learn and research on, then the Ayush subjects can become much more integrated in a scientific world that is today. So these are the steps I have proposed to in one of the meetings, introducing yoga for all the courses of health as a postgraduate diploma or a MD degree as well. In fact, 2 centers are producing MD in yoga, and a few other courses I am recommending that to happen over course of time. With these, I stop here. There could be shortly a overarching inclusive health commission as against what we have a National Commission for Indian System and a National Commission, a Medical Commission. These 2 bills have recently been approved. They have become acts. Perhaps sometime down the line, we will have a National Health Commission which is inclusive of all specialities. So I stop here. I thank each one of you for being with me. Danke gut.
The next speaker will be Dr. Sanjay Phadke. He is here today as the chair of the task force of the Indian Psychiatric Society for Mind-Body Medicine, and he will talk on this topic and explain us what they are planning and working on. Please, Dr. Phadke.
So thank you so much. It's a great pleasure to be here this evening, and greetings from our National Medical Association, which is the Indian Psychiatric Society. I am going to, in a very brief, because we had the great benefit of listening to Professor Sartorius in detail, and also Professor Gangadhar gave the outline as to what all things are going to happen in near future. I am going to tell you about the initiatives which we are going to take as a professional association. As you know, large part of medical care in India is still in the private sector, and this medical association, it represents psychiatrists both within the private sector as well as the government sector put together. So it's a kind of a view that we are trying to evolve through this. Next. This is a very important photograph. This is, of course, Professor Sartorius, and this is Sanjay Phadke. So exactly, this was exactly 25 years ago. And as all of you would have experienced here a short while ago, that once you listen to him, even once in your lifetime, it leaves a deep impact on you. Okay, so I was the lucky one to listen to him exactly 25 years ago in 1994. It left a very deep impression on me, on my overall thinking. And when I thought that Indian Psychiatric Society is ready to form, this task force, which, as he said, would try to reverse the fragmentation, which he rightly described in the medical domain, which has happened. So I thought that the first person, with whom we should again kind of get back to is Professor Sartorius. So it's my very great pleasure, sir, that you are here today for this particular one. So next year. Already described by Professor Sartorius that we live in a world which is changing. It obviously always changes all the time. Now, when we mean it's changing, it means it's changing rapidly. Too much rapidity with which we are finding a bit hard to really cope. India is changing, health scenario is changing, and we have multiple challenges, as again he very rightly said. So we have the changing disease profile challenge, changing demographics, aging. Although we say that India is a country of young people, but in actual numbers we have a very large number of aging population even in India. Everywhere else we have this problem. Then a very significant disturbing trend of rising incidence of lifestyle and mental health issues even in the young. And wherein again as he eloquently described, comes in the role of the incorporating prevention as our overall interventions, not merely looking at treatments, but looking at prevention and of course the access and the affordability. Effectively, therefore, we are really looking at, if we have to conclude it something like that for ourselves, the goal is we actually are looking at smart solutions, because enormous amount of research exists practically about every aspect of these things, but we have a singular difficulty to translate what research has made available into the real practice. So to tackle, with this, all this change, we really need smart solutions, we need smart diagnostics, early detection, or even better, predictive medicine, detecting risk ahead of time. Later some presenters are going to talk about that. And then we need smart inventions which are scalable as in which can reach out to large number of people, which are effectively practical, not merely very idealist but very practical. And can we have more participation of people in their own health matters? Again, in theory this has been talked for a long time, but from passive recipient we know, despite all these efforts, pharmacotherapy has remained the main modality world over for our interventions in last many years, and where the patient basically is a passive recipient of healthcare. Can there be a slight shift of the role in terms of, can the patient become an active creator? Can he become more participatory in one's own health process? And what can we do, as professional association, what can we do as doctors about that? So that is one point which we really seriously like to discuss. And in this context, this whole idea of mind-body medicine emerges as an attractive candidate. To which we should perhaps look at giving a serious shot, and that's why we are here with this task force. Just for your information, this is you can say the typical understanding about mind-body medicine. Initially it was all introduced to tackle the stress issue, to basically enhance treatment outcomes, prevention, quality of life, everything which Professor Sartorius mentioned. But the important thing here is, because you are looking at the patient as an active participant, so learning self-regulation is important. So it involves learning. Taking a pill doesn't involve learning. The only learning happens is how to take the pill every day. That is the only learning involved in taking a pill. But the main modality here is a learning, which we are kind of trying to incorporate. And learning is not merely about the information about the disease, but how one could self-regulate the state of health and whether it's possible. It has incorporated traditional methods like yoga and meditation, and also positive psychology. And for the Indian context, we thought that exercise and nutrition also are important, because of the large comorbidity that we are facing in India today. India has approximately, I think, 80 million cases of diabetes today. My diabetologist colleague is here, which is a very large number. 80 million people is perhaps the population of some of the smaller countries. Our diabetes load is that large, and with all this comorbidity, and of course integrated with the medical treatment. Now, if you look at actually all this research, all this information is available to us for quite some time, practically you can say for over a century. All this information, that how the mind is connected with the body, and how the nervous system, autonomic nervous system work, and how the hormonal system work, and how the immune system work, and how all these factors are actually affected by the person's psychology. And on the other hand, as per the Harvard Medical School, already we have enough information to that. When you make these kind of clinical trials in controlled situations, a number of conditions in which one could kind of try that. But despite that, the tragedy is that on one hand the need exists, and on the other hand the know-how exists. Somehow it has not been able to reach out to people in the form in which it should have reached. Very eloquently, as he put, the fragmentation. The fragmentation is not only between the mind and body, but even within the kind of different components of it. So question is that what does one do? Some great individual, he said that, doing the same thing over and over again and expecting different results. So if we expect some different results, we perhaps have to do some different things, because keep doing the same things is perhaps not going to get us to anywhere. So we are therefore looking at, within our approach, a pragmatic kind of approach, not a very idealist approach. And the goal which we have given to ourselves is from a 2-minute mind-body medicine to 360 degrees, very comprehensive, entire range. So what is possible if I have only 2 minutes with a patient, if a diabetologist has only 2 minutes with a patient, additional 2 minute, additional 2 minute, can the diabetologist do something for the patient's mental health as well? 2 more comprehensive programs, so creating mind-body health during routine consultation, then scheduling perhaps special consultations, workshops for patients, to interdisciplinary clinics and assigned clinical goals. And in this whole situation, we are trying to therefore develop the specific learning goals, as to what exactly which kind of could in a incremental graded manner can go to. So common elements and personalized elements. In terms of concrete action, we have on this entire philosophy, we have organized first and foremost our duty is to the Psychiatry Association. So in November 2019 at Bangalore, this National Institute, we have organized a national workshop for the psychiatrist. So first effort we make to train the psychiatrist. Then we train the diabetologists, and then we try to have kind of this nice alliance. Okay, so I stop here. Okay, thank you. Thank you.
Now I ask Professor Varambally to speak. He is in the same institute where Professor Gangadhar is the head. He is responsible for yoga research in this institute, and he will also be responsible for the first Center of Integrated Medicine in India, which is a model for India and maybe for the world, how all medical systems can be integrated worldwide. Please, Professor Varambally.
So yoga comes from, I'm sure all of you are, have done more yoga than me and you will all know this, but it is important to highlight one of the definitions of yoga that comes from the Bhagavad Gita. Bhagavad Gita, as you all know, is one of the most ancient texts in the Hindu religion, which talks about Samatvam Yoga Uchyate, which means yoga is basically equilibrium. Being in harmony is yoga. That's what this definition says. And much later, of course, Rudyard Kipling in his famous poem If said the same thing, that if you can treat success and failure both as imposters and treat both the same, then you are a man or a woman. I mean, at that time, I think men included women, but that was what he said. So this is in Bhagavad Gita, which is thousands of years old. He defined yoga as being in harmony. So this is what we've been doing at NIMHANS. We had yoga research from the 1970s, primarily in clinical psychology and neurophysiology. We then started work with Art of Living. Sri Ravi Shankar, who is a famous person in India, he has Art of Living Foundation. We have a yoga university in Bangalore called S. Vyasa, which is the only full university only for yoga in India, which gives degrees from 6-month yoga course to PhD. And then we had an advanced center in collaboration with an institute in India, and in 2014, NIMHANS, which is a national institute in the area of mental health, started the own yoga center. So we have our own yoga center as part of the hospital. Next please, if I can do it. Yeah. I won't go through this slide, it's a very heavy slide, but this is just to say what are the things we are doing. We see around 1,500 patients a month, that's around 60 patients a day. All of these are patients with mental illness. This is not a yoga center for normal people, no, it's only for patients. We have PhDs going on, MD Psychiatric doctors do the research on these patients in yoga. We produce a newsletter every 3 months called Samatvam. We do a lot of research, we publish, and two of our publications from NIMHANS on schizophrenia, yoga for schizophrenia, were picked up by the NICE guidelines in the UK, which is a health guideline, which for the whole of the UK, United Kingdom, and they have added yoga as a complementary treatment for schizophrenia for the first time in 2014 based on these studies from NIMHANS. Next please. This is what I was talking about, the number of patients. As you can see, slowly the number is going up, and this is the most important thing. Writing papers and publishing, of course, is important, but are the patients better is what the question. It seems so because they keep coming back. More and more patients are coming. Next please. What we do, we don't want to subscribe to any particular yoga school. We don't copyright the yoga, or we say, no, only I can teach this yoga, nobody else can teach. We don't do that. We produce what we call a generic module. Like what Reinhard is doing here, it's excellent work. You teach a yoga which you think is good, and then you allow anybody to teach that yoga if they do it properly. That's important. Otherwise, it will never reach. If you patent it and put it in your pocket, and you will get rich, of course, but patients are not going to get it. So we have now come out with different yoga for different schizophrenia, depression, memory problem, attention deficit in children, pain and other somatoform disorders. Klaus Post was here talking about this yesterday, OCD, substance use, alcohol, drugs. For that, what is the yoga that you should do? Make it simple, give it to everybody. Whoever knows yoga can teach it. That's something. Yeah, next one please. I'll just give you two examples of some research that we have done. This was done in the late 90s and early 2000s, a randomized controlled trial looking at only yoga as a treatment. In comparison with medicine, imipramine is antidepressant, and ECT, shock therapy, which is a treatment for very severe depression. So we compared, and as you can see here, I think this will work. Yeah, this is ECT. So ECT was the best, of course we know that, that's why we use it. But there was no major difference between medicine and yoga. So yoga was as good as medicine. Next one. This we replicated. Replication is very important in psychiatric research. One study is nothing. You have to repeat. And therefore, we found again that people who do yoga, whether they take medicine or not, they get better. Some of these people were not at all taking any medicine, they also got better. These were taking both yoga and medicine, they also got better. But the people who took only medicine did not get so much better. Now, this is a recent study. Next one please. Now the other major condition, schizophrenia, as you know, is the most severe mental illness. People suffer from delusions, hallucinations. People are called crazy. That's the typical mental illness. And what we have done is looked at the patients with this illness. Next one. And this is a paper that we published, which was, as I reported in the NICE guidelines. And these people with schizophrenia have a lot of symptoms, delusions and all that. But what is most difficult is they lose the drive, the will to do things. To have a family, to talk to your parents, to work, to go out, they lose that. That we call as negative symptoms. What should not be there in a normal person, they lose their drive and they don't do anything. They sit at home, don't want to eat, don't want to dress. That is very difficult to treat with medicine. Whereas yoga seems to help that. As you can see, the negative symptom got better. Next one. We did another bigger study. Dr. Gangadhar did this study, who just spoke to you. And again, we looked at yoga versus physical exercise, weight list. Exercise is slightly better than nothing else, but yoga was almost 5 times better than either of them in terms of negative symptoms. Next one. So this is what I said, it was picked up in the NICE and yeah, can go on. But how does this happen? What does yoga do? It improves your ability to empathize with other people. You connect with other people. This is called social cognition. If I look at you, I know whether you are happy with me, you are not happy with me. If Reinhard starts doing this, he says, I should close down. I know that. But a person with schizophrenia does not know this. He is unable to recognize the emotion of the other person, and therefore they fail at social relationships. Is my wife happy with me? Is she angry with me? I should know without her telling me. I look at her face and I know. People with schizophrenia lose this ability. And yoga seems to give it back. How it does that, again we have done a lot of work, but I'm not going to go into a lot of details. Next one. This is something that I put in all my slides. Dr. Sanjay warned me that some people may not like it, but I just put it to show what you do is important, but how you do it is also important. You know, the posture is very similar, but the effects next day morning are likely to be very much different. As you all know, this is Sri Iyengar. Everybody knows him. Of course, I don't know this person, but I would expect that next day you would have a severe headache. You know? Yeah. So this is why I put this slide, because alcohol is a serious problem in India. And we have looked at yoga. Many people who drink tell, I am depressed, so I drink. You know, if they do yoga, what happens? Depression gets better. Maybe they don't drink. You know, that's something that we are trying out. Next one, please. This is a summary of what we have been doing. So schizophrenia, symptoms get better. What we have seen is the hormone called oxytocin becomes more. That is the love hormone or the bonding hormone which connects mother and child. Maybe that is the reason why they have better empathy. You know, in depression, symptoms of course gets better. There is a neurotransmitter called as the brain-derived neurotropic factor. It marks how well your brain can repair itself. That gets better. And in elderly, living in the age-old home, we were actually able to show after 6 months of yoga that a part of the brain became bigger. Hippocampus, that is the critical thing for memory. So this is a summary. Next one, please. So this is the last slide. This is what we are trying to do. So this we have already done, as Dr. Gangadhar said. This we are already doing. We are training people from various backgrounds in mental health. This is what we do in the future, combining Ayurveda and yoga and having a integrated system. Next slide. So I would like to acknowledge my collaborators. Next one, just put a photo of our team. Thank you very much.
Now I welcome Professor Leena Phadke from the Medical Institute in Pune. She is one of the most important heart rate variability researchers, general and also on yoga. She will talk on Skype to us. Please, Professor Phadke.
With the global leaders of health, like Professor Sartorius and my colleagues from India. So why the new conceptualization of health? As you are aware that the landmark definition of health is under criticism for many points, that it is being idealistic and there is proneness for unidirectional medicalization of society. The operationalization of this definition is difficult as the statement complete well-being is practically not measurable. It's counterproductive for people suffering from chronic diseases and label them perpetually ill. It minimizes the role of individual resilience and there is more bias towards the societal interventions. And health hardly a static state. So there are a lot of points under which the classic definition of WHO is been under criticism. So we try to see the health from a different perspective, and the most important one is that the health is a dynamic but stable condition. To understand the meaning of this dynamic but stable, I have just given you an example of our solar system. As you are aware that Earth revolves around the sun and it also rotates around its own axis, so it is constantly under motion. And because of the internal and external forces which are acting on it, keeps it stable in its own orbit. Similarly, the health is a dynamic condition. And why I am saying it's dynamic? Because it has to continuously adapt to the environmental challenges and the internal process which are acting in the body, which also includes the aging of the system. So health is not a static condition or a static phenomenon. The next important is that health, this dynamic stability, manifests has variability. To give you an example of this, what does the variability mean, I have again used the example of our lunar system, where you know the lunar cycle, that every 1 month you are having a cyclic changes in the phases of moon, what we see as the phases of moon. Similar variability is there in health also, which is manifested in a form of biorhythms. And to give you examples of this, hormonal rhythms, we are having hormonal rhythms, sleep-wake cycles, hunger-satiety cycles, and autonomic rhythms. All these rhythms, they are the indicators of this variability. The variability, presence of variability is sign of health. I have just given you 2 examples of it. On the left side, you are seeing a graph. And 2 graphs are there on your screen. The left side of graph is showing more of fluctuations. These are the records of heart rate variability, which is a marker of cardiac autonomic activity. On the right side, you see a graph which is almost flat. The right side graph you see in diabetic patients. So what it suggests is that as the body moves towards the disease condition, it is indicated by this loss of variability. So a healthy state can be, you can say, measured by how much variability in the system is. This is a little bit more technical kind of presentation, but I'm trying to give you the more important your concepts that are there from the point of view which we have to understand the health. The next important is the health as a dimension. So it's not that health is not a discrete phenomenon. It's a continuum. So on one side you can see a green zone which we can consider as a healthy state, which means system is in order. And the extreme right side you can see a red zone which indicates a completely disordered system, which you see in a complication, disease complications. So a healthy system doesn't directly jump from its healthy state to directly extreme disordered stage. It passes through lot of various stages that you can see in the graph. The yellow zone, the orange zone. The yellow zone indicates a condition called as allostatic load. I will tell you a little bit about this when you read this, what this allostatic load means. And the next stage of this allostatic load is the disease stage. So the condition, it passes from the order of system, it actually progresses gradually towards the disorder system. These mind-body interventions, they may be pharmacological and non-pharmacological. They try to bring the disordered system more towards. Now, what this allostatic load means, that if you give a stressful stimulus to the body, it reacts to that stimulus. You can see the cyclic pattern that is there on the graph. And once the stimulus is removed, the system returns back to its original set point. If the stimulus is continuously given, you can see that there is a heightened response of the system and it doesn't return back to its original state. So there is a difference between the normal set point and a new level of set point of the system. And this difference is called as allostatic load. So whenever the different types of challenges, whether it's internal or external forces acting on the body in a continuous way, they create this allostatic load, which you can call it as a pre-disease state. And this allostatic load, if the stimulus is continuous, even after this load, then the body slowly progresses towards the disease state. Now the next important concept that is there is the resilience. I think it's a very important key component of this newer health model. It is a capacity and the ability to recover from difficulties or adapt to changes without being damaged. The resilience building is, I think, the goal of which an important goal of this newer model of health promotion and prevention. And unfortunately, it has got you can say, less importance compared to the societal intervention. A little bit about the autonomic nervous system, the control system of our body. It's an important system that contributes in resilience building. It's a fastest connecting link between the body and mind, key integrator and modulator of physical functions, and predominantly responds reflexively to external and internal stimuli. This is what is the normal, you can say, the non-linearity is a feature of a healthy control system, and if it moves, the non-linearity is a mathematical concept, and if it moves, the system moves either towards more determinism or towards randomness, both the conditions denote disease. And HRT can measure the nature of control system. And then why we are interested in autonomic resistance and yoga, it's because I think this system is important for resilience building and different postures. We are interested to look at the effects of these different postures. Vis-a-vis gravity, they pose a novel challenge to the nervous system as against the fixed stimulus of routine posture. So we conducted series of experiments with yogasana and look for its response and look for the autonomic response to these challenges. So we conducted, we recorded HRV in different postures and direct comparisons of yogasana with aerobic exercise, modified asanas in yoga name individuals, and then effects of asanas and their variations in trained yoga practitioners. Key finding, and what we have observed is that this is a new concept with yoga asana. It possesses circulatory conflict. Specifically in this inverted posture, it possesses a circulatory conflict, and yogasana poses a perceptual conflict, and how our body reacts to it, how the autonomic nervous system reacts to this kind of conflict. And this is what we have observed is the differential modulation of awareness during different yoga asanas. What it means is that you can see this, that there is a graded vagal withdrawal or augmentation and baroreflex modulation, which is different in different asanas. So all the asanas doesn't produce the same kind of effect in terms of autonomic response. And ANS deals with this novel stimuli in a very intelligent way by resetting the sensitivity of autonomic receptors. Reflex responses are overridden by the complex responses, involves prefrontal cortex, long loops are involved, and all these mechanisms increase the resilience of autonomic nervous system that it turns into the resilience of the body. I think it's the last slide. A little bit about the predictive medicine. It's an approach for health promotion. You can see on this spectrum again that if we are able to pick up the patients in a yellow zone or an orange zone, what it means is that if before the appearance of the clinical symptoms of the disease or the appearance of symptoms of complication, if we are able to pick up the person, then we can be able to promote the health in a better way rather than after the, as Professor Sartorius has said, that prevention is better than cure. So if we are able to pick up the patient in these cases, predictive medicine actually acts in this way. And these are the applications which are
we cannot realize, so I think we clap, right?
The next speaker is Dr. Hedwig Spegel from the Bavarian Health and Food Safety Authority. She will talk on health promotion, how it is done in a Bavarian institution. Please, Dr. Spegel.
I want to talk how we make health promotion, or we can make it in workplace scenarios, by the example of a Bavarian authority. We also have as one activity yoga. We try to motivate our employees to take part in health promotion activities. So, for example, when they go and regularly go to the courses, they get 40 minutes out of 60 minutes count as work time per week. We supply them with materials, for example, yoga mats and other tools, so that they don't have to carry and bring it. And we also make subsidization by the LGL with that we pay some part of the costs, if not supported from our health insurance. And this is a little summary. How can companies benefit from offering yoga? Yoga supports people at work, for example, getting better concentration, in efficiency of work and regeneration. And it is suitable for all age groups and for most pre-existing medical conditions. Is cost efficient, and it is very easy to implement. You don't need much things. You need a room, you need a mat, and you can start with yoga, but you need a good teacher, of course. And it strengthens corporate feeling. The companies, of course, can benefit from yoga, but also the employees, so it is a win-win situation.
The next speaker is Professor Deshmukh. She is from the Indian Endocrine Society. This society is the first society which took the mind-body medicine idea for her society and wants to develop it. Please, Professor Deshmukh.
Yeah, good evening, ladies and gentlemen. It's my pleasure to share the dais with Professor Sartorius, and I thank Dr. Phadke and Professor Reinhard for it. And I'm an odd man from the whole lot, I think. I'm an endocrinologist and a diabetologist. And I'm mainly here because this question was asked to me on various forums as why I am involved in mind-body medicine. And then came the question of what hormones do to mind and what mind does to hormones. And this interaction, unfortunately, has been neglected in endocrinology for a long period of time. And this was an occasion for me to actually emphasize how hormones are very important and crucial part of mind-body medicine. And that is why we've started this work with the Yoga Forum, as well as the CBM Trust, and our trust works on this theme of mind-body medicine in endocrinology. So we know that this is the data from India correlated with different studies that nearly 30% of diabetes in India are known to have associated depression and psychological comorbidities, and this is worse in thyroid. So in thyroid disorders it's still more, and we all know that obesity has a causality as well as an effect on psychological comorbidity, and that is why if these are the three prime disorders that we see in endocrinology, why aren't we targeting it is a question. So why aren't we treating mind? And if you see all the guidelines, all the associations, especially in endocrinology, don't focus a lot on mental health, and that's a unmet need that actually I find that is a major disturbing part of the whole thing. And probably there is a focus of putting stress as an endocrine disorder rather than a separate entity as such, because you see that stress works through various hormones like cortisol, through insulin, and so many patients in India are getting diabetic in spite of the best of healthcare available in diabetes and prevention. So that's the tragedy of the scene, that we are not able to halt the occurrence of these non-communicable diseases, which is very much in our hands. So are we just focusing on reactive medicine, or should we be more proactive, is what is the question. So reactive in the sense that I'm focusing on treating diabetes complications, but what am I doing so that diabetes does not occur at the primordial level or the primary level? So that's the question, and there is the role of identifying the mental risk, the stress markers, and the allostatic load, and we heard the previous speakers speak on that, and improving your resilience, improving your immunity and your adherence. I'm sure this is going to translate into improving compliance, adherence of anti-diabetic medicines, because that's a big issue in diabetic practice. I'm sure that in any non-communicable disease where you have a long-term therapy, adherence is a big problem. That's a major issue in diabetes, and we are facing the consequences of that. And I'm sure this is a global problem. So there is an unmet need of tackling this mental health in all the non-communicable diseases, especially in the field of endocrinology, diabetes and thyroid. And treating beyond body is what needs to be rather percolated into the faculty. And does it always need a psychiatrist is a question. Are we trained enough to treat mind as endocrinologists, and designing psychiatry referral guidelines for specific illnesses, specific conditions and specific outliers is, I think, a need of the hour. And scoring of this kind of this outlier system is a need in the sense that if you have a bell curve, I'm sure you know that on an average most of the patients would have some or the other psychiatric disturbances in a dynamic state. Not all would require psychiatrists, but definitely you would have the outliers who would definitely need to see a psychiatrist in the long run. So one needs to be very sure as an endocrinologist or a diabetologist as to whom I should refer and whom I should treat myself, and whom doesn't need a psychiatrist, because there is a taboo associated with referral to psychiatrist. I'm sure in India nobody wants to go and see a psychiatrist even though the patient is depressed. I can see that. And there is a role where I can educate the patient at my own accord and treat the patient's psychology at my own accord instead of referring to the psychiatrist. So this was an endocrinologist survey done in India. This is what when we started with our work on MBM, and we found that nearly 50% believed that yes, mind-body medicine is very important and it should be tackled, and we are doing something to help that. We are either having psychologists or psychiatrists in association, and there were other 30% of people who said that we have heard about it but we don't know how to implement it, and there were another 10% who said I don't believe that there is something called as mind-body medicine which is required, and 10% said yes, we would like to know more. So I think there's a lot of work to be done in the field of diabetes, and this is where our society works. We are doing patient workshops on positive psychology, helping them reduce the stress. We have a MBM clinic, that is a mind-body clinic which runs parallel with a diabetic clinic, and we are of course arranging a conference for endocrinologists in January. I welcome you all for the conference. We would definitely want Professor Sartorius to definitely guide us on this, and we are most welcome to have all of you. And these are the activities for future. So our diabetic clinics at the doctor's level, we are planning mind-body health assessment of each and every case of diabetes, so that they have some assessment. We have nutritional assessment, but we hardly have mind-body assessments. So that's one need of the hour. Then scales to identify referrals, then defining role of so-called mind medicine. So most of my patients would say, madam, why don't you give the antidepressant? Why are you referring? So how many patients can we really give some mind-body medicines to help their depression or psychological disturbances? I'm done with just 2 slides. And protocolized and basic prescription for mind-body health is a need, and practical tips as to how to implement these activities in practice is a need. And then there is a role of community outreach, which we are going to the press, print media and digital media, which is definitely supportive for this. Implementing this in other fields of oncology, gastroenterology, where psychosomatic disorders plays a role. And of course helping physician burnout, because I'm sure most of the endocrinologists in India definitely are burnt out. I can assure you that. And at the national and international level, probably a collaborative group would be of help, and reaching different societies worldwide, and definitely research with the help of yoga groups and other alternative medicine would definitely be of importance to this. Thank you so much for the
The honor to close the symposium is on me. The topic: learning, health promotion, mind-body medicine and yoga. Most of the speakers who were speaking, and Professor Sartorius started, that learning is a big part of health promotion. So I am very happy as a person from learning, from education, that so many speakers have already made the foundation so that I can be quick. This we can also drop. When we go to that, this is what we think is surrounding for learning. There's a person, there's a inner psychic somatic learning, there's a surrounding, there are other people around it, and nature and whatever, and there's a learning. So this is a double relation, the person with itself and the person with the surrounding. And in this learning happens. So we can go to the next. The interesting thing is nowadays, and I got this from Dr. Phadke, and I took the original from CIS in 2015, that neuroscientists are thinking the same way, but this is a luck for us, bring it into details. They have the same, this is a tomato, this is representing the external world, and this is the proprioceptive, that is the whole body and muscles and all that, and the interoceptive, this is the mind and the inner organs and whatever, and then they have the idea somewhere in the brain this must be coordinated, and the problem is, how is this coordinated? Next please. Then of course Antonovsky was the most important person to start this idea of salutogenesis, opposite to pathogenesis, so that there is also a development of health required, and as similar to the development of disease. And I had the luck to get Dr. Lüthi as a partner who was very near to Antonovsky, so we thought his idea of a health disease continuum, what could we do with this in a practical health promotion and learning, please. So, yes, okay, it's okay, this is good. So we thought when we are really work with people, we have to understand in which point, and this is a little bit of the extension what Professor Phadke showed, on which point of the continuum the person is, to help the person to learn what is important in this point of the continuum and then go ahead. So what we did, and we published it in 2000, we did try to make it parallel for the whole medicines of the world. And Professor Gangadhar, he said this is a problem of India, but it's a whole world problem, that we have different types of medicines in the whole world, and that we have to understand how they fit together. And I think they don't fit together internally, but they fit together when we look at a person. So we can one important concept was stress concept, so that stress from diseases starting from stress. So we can say, okay, there are diseases starting from stress, or there is no stress, like that. So we can use the stress, or we can have the public health concept, which you also pointed out, primordial, primal, secondary prevention, and tertiary prevention and all that, or we can go to this primordial state. So we were most interested, of course, in this part, in the more health part, and not so much in the disease part. Or we can go to Ayurveda, very interesting. They describe in details these 6 stages. And they classify in which stages you are. And they say in each stage, what is the activity of the doctor to help the person to come out of this stage, and it's all 6 stages of disease development. They think health is before disease, stage 0, then what? All these stages. So, and also in yoga we have ideas about the stages of dysregulation and regulation, and Professor Phadke explained very nice how it comes in stage 4. Her description of this allostatic load was, it comes in stage 4, and it is a new stabilization in stage 4. Then our question, of course, and this Roland Lüthi was at Bern University with studies on health promotion in companies and diseased people and what can we do and all this. The question was, how really can we help the people? So basic idea is clear. We have to identify where the person is. Of course, on several levels. It can be in one level on this stage, in another level on that stage, and so on. It's not just a fixed thing. And we have to understand the levels, and then from that on go into either it is nutrition, or it is behavior, or it is back pain, or whatever. There are several levels. So learning, and Dr. Phadke also pointed out, learning is, and you, Professor Sartorius, we in education think we have this term Mündigkeit. This comes from Kant. And Kant, he was saying that the person has to create freedom, in not dependent from outside things, not dependent from wrong inside thing. And how can this be reached? So in education, this is a topic since Kant, how to go forward and how to learn that. And also my education teacher, he was this was a big topic. So we have to make a person responsible for his own health, but not only inside, but also outside. Okay, then next thing. This is the last slide. And so I have a bit time to stay at this. As also Dr. Phadke pointed out, we need regulation. When we find a person, let's say what Professor Phadke pointed out, in this stage, then we know, and this is very important from also systemic thinking, that a system, a dynamic system, has a tendency to stabilize itself in a new stage. And this is the biggest problem. Psychological systems stabilize themselves in a new state, bodily systems stabilize themselves, social systems stabilize them in a wrong state. And how can we come out of this stabilization? This is when we look at Dr. Lüthi's teacher, he was in smoking. Then we see the smokers, they stabilize themselves. So they know everything about what is unhealthy with smoking, but they smoke. And you know better, Professor Sartorius, the smoking in change in Europe, it was not by health promotion. It was because an Italian company was brought to court, and then they had to pay for a person who was sitting next to the smoker, and then everybody said the rule was all in Europe, this is in Europe, and so on. So this is other examples where we have to look how really works it. So you can say smoking was changed in Europe because of this social event that a court in Italy made the change from stabilizing this to this, and then we had all no smoking in restaurants and whatever. You know now what happens. It was not because of what we think good health education programs. So maybe we should support lawyers to find solutions for health problems and make training. You can make your basic training not only for doctors, but maybe you can make your basic training also for lawyers, how they could find, yes, this is serious, because we have to find regulation which happens. Okay, thank you. So my example, of course, is back pain, low back pain. Because we know there is low back pain a lot also, and then normally there's little medical treatment in this stage 5, and also people can do a little yoga. I had people with strong problems, and they started with little yoga together. Then we can bring them in stage 4, massage and all that. And then the next is, how can we bring the whole psychological, social, muscle to bring the load from the wrong place to the proper place. And this is the main change. Then we can stabilize the load on the proper place, either it is physiological or psychological, and then we stabilize it more, and then at the end we come to a balance. So you can say this is only an example. We can make a lot of examples how this really practical works, and we now in companies, outside companies, with yoga teachers, with me here, there, with the patients, we have a lot of experience last 40 years how this is practically possible, and I'm very happy that the modern theories of brain research and all that support us very much to go ahead with that. So in this sense, this is the end. I thank everybody very much for coming. Yes. So now come. Come. So, first of all, for you, a small present, and thank you very much for coming, Professor Sartorius. Thank you very much. Then I go ahead with Hedwig. Thank you very much for coming, Dr. Spegel. Thank you very much.
Slow.
One for you.
Thank you.
One for you.
Thank you.
One for you.
Thank you.
Yes, we have enough. We get also one for you. Yes, we get one for you. Okay. So now the traditional Indian people, of course, they also want to give a present.
I like to express that to an outlooker, this meeting perhaps would have looked like actually the pre-election speeches, which politicians make. But we would like, to assure all of you here that we would like to come back, maybe in a year's time with whatever concrete actions, that we make. I think it was more of this meeting was more of an expression of intent for all of us to come together and to demonstrate that, we possibly are going to exhibit some commitment, to these ones. So please, sir. So it is my pleasure. Of Indian Psychiatric Society and all of us here, Yoga Forum, CBM, Endocrine Society, thank you so much and keep us blessed.
Thank you.